With most infections or infectious diseases, such as strep throat or pneumonia, you usually become sick right after the bacteria, a microorganism, enters your body, and you become sick within 1 or 2 weeks. Tuberculosis doesn't follow this pattern. Tuberculosis occurs in stages. So there's a primary infection, a latent infection, and then active disease. Except for very young children and people with weakened immune systems, very few people become sick immediately after tuberculosis enters their body. This stage is called the primary infection, when the bacteria first enters the body. In most cases, the tuberculosis bacteria that enter the lungs are immediately killed by the body's defenses. Bacteria that survive are engulfed by white blood cells called macrophages. So then these engulfed bacteria can remain alive inside these cells in a dormant state for many years. And these sort of dormant cells are then called tubercules, and they have these long periods of inactivity, and they're very resistant to any kind of treatment. This stage is called the latent infection. In 90 to 95% of cases, the bacteria never cause any further problems. The person just exists like that. But in 5 to 10% of infected people, these bacteria eventually start to multiply, and then the person moves into the active disease stage. And at this stage, infected people actually become sick and can spread the disease. So let me just break this down. Primary infection is in the first few weeks of the infection. The bacteria travel from the lungs to nearby lymph nodes that drain the lungs. These lymph nodes are located just outside the lungs where the bronchial tubes enter the lungs. And in most people, the infection goes no further. The bacteria become dormant or latent, and they do not cause any symptoms. However, young children and people with weakened immune systems may develop pneumonia and or tuberculosis that affects other parts of the body. That's called extrapulmonary tuberculosis. It happens outside the lungs. Also, in young children, the affected lymph nodes may become large enough to compress the bronchial tubes and cause symptoms. Usually, the infection is not contagious during primary infection. Then during latent infection, now this is the next stage, bacteria remain alive, but in a dormant state inside the macrophages for many years. The body walls off the bacteria inside a collection of cells which form tiny scars. In 90 to 95% of cases, these bacteria never cause any further problems. The infection is not contagious during the latent infection. And then finally, active disease. At about 5 to 10% of infected people, these dormant tuberculosis bacteria start to multiply and cause active disease. At this stage, infected people are sick. They're really, really sick and can spread the disease. More than half the time, dormant bacteria reactivate within the first 2 years after primary infection, but they may not reactivate for a very long time, even decades. And usually, doctors have no idea why the dormant bacteria reactivate, but reactivation is more likely to occur when the person's immune system becomes impaired due to things like very advanced age, HIV infection, or the use of corticosteroids. So there are many ways to screen for tuberculosis, and we try to differentiate between a latent infection and active disease. Because the tuberculin test does not separate between the latent infection and disease, the active disease state. So infection, to be diagnosed with the latent infection, and remember, no symptoms, they're not contagious. So it includes the presence of tuberculosis organisms, the positive tuberculin test, a normal chest x-ray, and no symptoms. The active disease stage includes presence of tuberculosis organisms, positive tuberculin test, positive chest findings, so there'll be something on a chest x-ray, and a positive sputum culture. So a tuberculin test that comes back positive doesn't necessarily mean that you can spread tuberculosis, and most of the time it will just be a latent infection. You need to have a positive chest x-ray to confirm that the disease is in the active disease stage. So a number of antibiotics are used and are effective against tuberculosis. But because tuberculosis bacteria are very slow growing, antibiotics must be taken for a long time, at least 6 months or longer. And treatment has to continue long after the person feels completely well. And now that's a struggle, because once someone feels well, they don't want to take antibiotics anymore. If they don't take them, the disease will tend to recur because it was not fully eliminated. And also, the tuberculosis bacteria may become resistant to the antibiotics. Most people find it difficult to remember to take their drugs every day for such a long time. Other people, for various reasons, stop treatment as soon as they feel better. Because of these problems, many experts recommend that people with tuberculosis receive their drugs from a healthcare worker who watches them actually ingest the pills. So this approach is called DOT, Directly Observed Therapy. And because DOT ensures that people take every dose, these drugs are often given just 2 to 3 times per week for the first 2 weeks. 2 or more antibiotics that work in different ways are usually given because treatment with only one drug leaves behind a few bacteria resistant to the drug. With most other bacteria, a few bacteria would not be enough to cause a relapse. But if tuberculosis is only treated with one drug, the tuberculosis bacteria soon become resistant to that drug. So we'll usually see 3 or 4 drugs used at the same time concurrently in all active cases. So typically there are 2 phases for treatment when patients or people, the treatment of people who have not been treated before. The intensive phase, where people take 4 antibiotics for 2 months. And these are used to treat active TB. You'll take INH, rifampin, PRZ, and ethambutol. So they'll take those 4 antibiotics for 2 months. And then the continuation phase, people will only take 2 antibiotics for 4 to 7 months, depending on the results of sputum tests and chest x-rays. If the 4 drugs are not effective in treating the active disease stage, streptomycin is sometimes added. And all of these drugs have side effects, but 95% of the people with tuberculosis in the active stage are cured with these drugs and do not experience any serious side effects. Now, if someone is found to have a positive tuberculin test but a negative chest x-ray, and they're determined to be in the latent infection where they're not contagious, they will be treated with INH alone. So that's used alone when the disease is inactive. And that's used to try to prevent the disease from becoming active and to cure the patient. So now we're going to take a look at fungal infections. So in our previous 2 and at the beginning of this Camtasia, we talked a lot about bacteria and curing bacteria. And bacteria are much different than our body's cells, which is convenient when it comes to creating drugs to kill bacteria, because they have cell walls. We don't have cell walls. And so a lot of drugs are targeted at disrupting cell wall synthesis, doing things to bacteria cell walls so they don't damage our cells. So the next few diseases, infections, drugs are not as effective at treating things like funguses and viruses because these organisms, viruses, are not similar to us, but they use our own cells, and by using our own cells it makes it very difficult to kill them without damaging our own cells. Funguses are a little different than our cells. We use cholesterol, which is a sterol, and that's useful in helping to build up our cell membranes. Funguses use something called ergosterol. So a lot of drugs are actually fungicides, or fungal agents are used at disrupting something with ergosterol because we don't have that within our cells. We use cholesterol. So fungal drugs are targeted at that sterol called ergosterol. So fungal diseases are often caused by fungi that are common in the environment. So you go outside, you start like jumping around in the dirt, fungus gets disrupted within the dirt, we inhale it. At any given time, just like we have bacteria, all different kinds of bacteria that live in our body, we have hundreds of different kinds of funguses that reside in our body, viruses that reside in our body, and we still feel pretty well with all these things that are inside our body. Because most fungi are not dangerous, but some types can be harmful to our health. Mild fungal skin diseases can look like a rash, and those are pretty common. Fungal diseases in the lungs are often similar to other illnesses such as flu or tuberculosis. Some fungal diseases like fungal meningitis and bloodstream infections are less common than skin and lung infections but can be deadly. Those are the systemic or the system fungal infections, which are much more serious. So the fungal infections that we're going to see in dentistry are called mucocutaneous. Those are basically thrush. We're going to see thrush inside someone's mouth. When we go to outreach and you work in a long-term care facility, you may see thrush, like a yeast infection in someone's mouth. And they are difficult to treat. So we're probably going to see thrush, fungal infections in patients that are immunocompromised. These fungal infections can become chronic. We're not going to be dealing with systemic fungal infections, the more serious ones like the fungal meningitis. We saw that in the news in the last couple of years. There was a compounding pharmacy right here in Massachusetts, and their facility was dirty. And they introduced fungus into their steroid injections. These steroid injections went to doctors' offices all across the country, and I believe over 120 people died from things like fungal meningitis and systemic fungal infections. They went in to be treated like maybe some of you have had those injections into different into your elbow if you have tennis elbow, or into your shoulder if you have a frozen shoulder. Someone went to have that steroid injection to be relieved from pain, and they had a fungal infection introduced into their body from this dirty compounding pharmacy. And they're charging the pharmacist that owned that pharmacy, I believe, with maybe manslaughter. So they'll be going to prison. So other fungal infections can include ringworm. We talked a little bit about thrush. That's what we'll be most concerned about. Pneumocystis pneumonia, which is a fungal opportunistic infection that happens. It used to be called Pneumocystis carinii pneumonia. Now it's called Pneumocystis jivaricii pneumonia. And this is a picture of what thrush looks like. You can see sort of like those white patches, and if you sort of wiped them away, you would see like little red bleeding points underneath. And the drug of choice for this will be nystatin. And let's just take a look here. Now, because many fungal infections develop slowly, months or years may pass before people seek medical attention. People with weakened immune systems, fungal infections can be very aggressive. They can spread to organs, leading to death. Several drugs are effective against fungal infection, but the structure and chemical makeup of fungi make them difficult to kill. Antifungal drugs may be applied directly to the fungal infection of the skin or other surfaces, such as inside the vagina or inside of the mouth. Antifungal drugs may also be taken by mouth or injected when needed to treat more serious infections. For serious infections, several months of treatment are often needed. So nystatin, that's the drug of choice for oral candidiasis, also known as thrush. So you could ask a person to do one of two things. They can swish, swirl, and spit, or swallow. You could also swallow the solution 4 times daily for 2 minutes. And as you know, even asking someone to swish for 30 seconds can be a challenge. So to do it 2 minutes 4 times a day, they're probably not going to do it. The nystatin pastilles are like little lozenges, like if you've ever had like a cough drop or like a Sucrets or something like that. You can stick it on the inside of the buccal mucosa and it dissolves slowly, and it can take up to that 2 minutes to dissolve. The only problem with the pastilles is that it contains sugar. So that could be problematic if the person already has a lot of decay. So that you can see that there's no perfect treatment. The pastilles will be a better option if the person is not going to remain committed to the 4 times a day, 2 minutes of the swish, swirl, spit, or swallow. All right, the pastilles may be better. You can also use creams that are indicated for vaginal use orally, because the creams that are used vaginally won't contain the sugar, but they would probably taste pretty gross, and the person may not be committed to doing it. So pastilles is probably the best option. So the azoles, these drugs here, these are the ones that block the synthesis of that ergosterol, which is an important component of the fungal cell membrane. So remember, funguses have ergosterol and we use cholesterol. So the ergosterol is a good target for fungal medications. So you can see I have in quotes up there, the azoles, because that means that the suffix azole is for an antifungal. All antifungal drugs, with the exception of aripiprazole, which is an antipsychotic that we'll talk about next week, all the other azoles are antifungal medications. So we have diflucan, ketoconazole, clotrimazole, and these are either local or systemic treatments for oral pharyngeal candidiasis. So perhaps if the nystatin has not been successful, you may turn to an azole to try to cure that thrush. So now we're going to talk about viruses, and viruses are really tricky. Okay, viruses, let's talk a little bit about what they are. So viruses are infectious agents that enter and replicate within our own healthy cells. Okay, so they're using our cells to replicate. So they're really difficult to treat because they use our cells. And we don't want to create a drug that's going to kill our own cells, because then that may kill us. So the virus enters our body. So in order for the virus to attach, receptors on the virus must bind to receptors on the outside of the healthy cell. So this allows the viral membrane to fuse with our cell membrane, and then basically the virus fuses with our cell and then spits its guts out, its genetic material, to inside of our cell. So once the virus replicates inside the cell, It can remain dormant for long periods of time, or it can be released immediately and attached to other healthy cells to begin the infection process again. So many diseases are caused by a virus. The flu, chickenpox, hepatitis, HIV. They can differ in symptoms such as fever and weakness. Some present no symptoms at all. The potential for recovery depends on the type of virus. Viruses may cause harm, and if left untreated, potentially death. Antiviral drugs usually work by stopping the infection process. Depending on the virus and the medicine, the blocking of the process can occur at different locations. One drug can prevent the virus from fusing to the healthy cell by blocking a receptor that helps bind the virus to the cell. By preventing this attachment, the viruses can't enter or infect the cell. Sometimes multiple drugs are used to treat a particular infection so that more than one viral process is disrupted and the chances for the patient's recovery from the infection are improved. While some viral infections, such as hepatitis or HIV, cannot be fully cured, a patient's state of health can be returned to normal by controlling the virus and preventing further harm to the body. And so here are some viral infection examples. We talked a little bit herpes, hepatitis, influenza, HIV, smallpox, rabies, and Ebola. So of these viral infections, one of them is 100% deadly if symptoms have appeared, and that is rabies. I think after symptoms have appeared, now it says 100%. 100% once symptoms have appeared. Now, there has been, I think, one in the entire world documented case of someone after symptoms have appeared that they have survived rabies. I'm not sure how well they were neurologically, but just like with anything, someone will survive. So rabies, even though it is documented as 100%, I believe one person in the entire history of the world has survived after symptoms have started. And the last case of rabies that has killed someone around here, I think, was back in the 1980s. It was down in Greenwich, Connecticut, a young girl, 10 or 11 years old. She lived in an older home. They never knew a bat had scratched or bit her. I guess the bites or scratches aren't very painful, and they think that she was sleeping and a bat may have come in through, I think she had like a fireplace in her room, and during the night a bat maybe bit or scratched her. They were never able to find out exactly what happened, and she ended up getting sick and the symptoms developed and she died of rabies. So here's just a little picture that talks about how a virus works. That darn virus uses our own cells against us. Here it is. It's attaching to our cell. It's basically spitting all of its RNA into our cell and uses our cell to replicate itself. And it keeps replicating virus here. Look at this. And then finally our own cell explodes and spits out a bunch of other little virus particles to go and make us sick. So treatment of viral infections has posed the greatest problem of all infectious organisms. Viral infections usually are not cured, but they're self-limiting. You get better, or you just live with them chronically. So let's take a look at herpes simplex. So both types of herpes simplex 1, herpes simplex 2, can cause oral or genital infection. So what does that mean? That means that you can have herpes simplex 1, the oral herpes, on your genitals, and you could have herpes simplex virus 2, the genital infections, orally. So most often, herpes simplex 1 causes gingivostomatitis, herpes labialis, and herpes keratitis. Herpes simplex 2 usually causes genital lesions. Transmission of herpes simplex virus usually results from close contact with a person who's actively shedding virus. Viral shedding occurs from lesions, but guess what? It can even occur when the lesions are not apparent. So after the initial infection, herpes simplex virus remains dormant inside a nerve ganglia, but it can periodically emerge, causing symptoms. So recurrent herpetic eruptions are precipitated sometimes by overexposure to sunlight, fever, stress, immunosuppression, or even an unknown stimuli. Generally, recurrent eruptions are less severe and occur less frequently over time. So anyone in the class that gets a cold sore probably knows that with some stress, you may start to feel like that prodromal tingling prior to the actual lesion erupting on your lip. For some reason, the dormant virus has become activated. And so we use antivirals, different antivirals for herpes simplex. You can use acyclovir, which is the prototype, and the topical, which means you rub it on the lesions, is approved for herpes simplex 1 and 2 in patients that are immunocompromised. And you can use it orally, a tablet, for herpes simplex 2 in the immunocompetent. So these cyclovirs, so we have Valtrex, valacyclovir, which is converted to acyclovir within our body. So we have Valtrex and Zovirax. They're really, the literature does not support that they're that effective in immunocompetent people for herpes simplex 1, for the cold sores you see on the lips. They don't do that much. So then we also have Abreva. That's a topical, and that's available without a prescription. It may decrease healing time by about a half a day, which doesn't seem like a lot. In patients with recurrent orolabial herpes, when started within 12 hours of that prodromal, when you start to feel those tingles, if you start rubbing Abreva on the site, it's not going to prevent the eruption of the cold sore, but it may reduce healing time by a half a day. And then our last cyclovir, Denavir. So this actually can reduce both the duration of the lesion and the pain of the lesion. And some of the advantages are there's a higher concentration within cells, so the drug duration in cells is longer. So it's been shown to reduce both the duration, the length, and the pain of the lesions, right? Because those lesions can really hurt on the lips and face, associated both with primary and recurrent herpes simplex. So Denavir may be a better option than Valtrex or Zovirax. But anecdotally, people do like to take acyclovir. They think it really helps. As if they've started it soon enough, they're really committed to it helping them. The literature doesn't support it. So these are our, if you see cyclovir as a suffix, C-I or C-Y, C-L-O-V-I-R, those are usually drugs associated with herpes simplex virus. If you'll notice, a lot of the drugs that we're going to talk about that have to do with viruses have VIR in their name. So if there's a question about viruses, start looking for that clue of VIR in the name. So now we're going to talk about HIV. So basically, once HIV enters the body, it attaches to several different types of white blood cells. And the most important ones that it attaches to are our helper T lymphocytes. and they can also be called CD4 cells. These T lymphocytes have CD4 receptors on them, so sometimes it's used interchangeably. T lymphocytes, CD4 lymphocytes, helper T lymphocytes with CD4 receptors. Anyway, HIV hunts for these particular cells, attaches to them, spits their viral RNA into the host cell. The RNA is converted to DNA and becomes incorporated into the host DNA by an enzyme called viral reverse transcriptase. See the ASE at the end? That indicates it's an enzyme. Then our host cell makes copies of the virus within that one cell, and then finally it bursts because it gets so large and spits out a bunch of virus to the rest of our body to have them go and hunt for more T lymphocytes with the CD4 receptors. So HEART, which HEART is actually an older term, highly active antiretroviral therapy. It's now usually just called ART, antiretroviral therapy. The textbook still calls it HEART, but usually now it's called ART in the literature. So these antiretroviral agents are used in combinations they're called cocktails to manage HIV infection. And they include nucleoside, reverse transcriptase, inhibitors. That's a whole long word. So those are usually just shortened to nukes. Non-nucleoside reverse transcriptase inhibitors, those are the non-nukes. Protease inhibitors, infusion inhibitors, and I think we're actually going to talk about something else called integrase inhibitors. So basically the drugs used to treat or manage HIV, one class inhibits HIV entry, and all the others inhibit one of 3 HIV enzymes needed to replicate inside human cells. So the majority of the drugs are focused at inhibiting enzymes, and one inhibits the entry of HIV into our cells. So these are the nukes, AZT, retrovir, there's that VIR is the prototype, and this is one of the ones. You can see nucleoside reverse transcriptase, so this inhibits enzymes. So it binds to the reverse transcriptase, preventing the viral RNA from converting to DNA. And these are our non-nukes. And I am not even going to try to pronounce some of these drugs. Look for the VIR. I want you to know basically the groups versus specific drug names. So the non-nukes work by binding to a different spot on reverse transcriptase that prevents the viral RNA from converting to DNA. So this is another enzyme inhibitor. So now we have protease, and I'm seeing the ASE here. So this must be another enzyme inhibitor. So this mechanism of action, it prevents the virus from assembling mature infectious copies by inhibiting protease. And this is our most powerful antiretroviral to date. Then we have fusion inhibitors. These are also called entry inhibitors. Now these are the ones that are not doing anything with enzymes. These do not allow the virus to initially attach to the CD4 cell, that CD4 receptor within this, on the T lymphocyte. So these are called fusion or entry inhibitors. And now we have integrase inhibitors, yet another enzyme inhibitor. I see the ASE within the name. So this inhibits the action of integrase, which is a viral enzyme that inserts the viral genome into the DNA of the host cell. Because integration is an important process of the retroviral replication process, it blocks it from further spreading the virus. And now this is a unique drug. in this drug, TRUVADA is the trade name of the drug. So let's take a look at this one. So this is used to treat HIV-1 infection because now there is an HIV-1 and an HIV-2. Anti-HIV-2 infection is less common. It's less virulent. Most of the infections that we see in the United States are HIV-1 infections. So TRUVADA is used to treat HIV-1 infections in adults and teenagers. When it's used the treatment of HIV-1 infection, TRUVADA is always used together with other HIV-1 medications. So as part of the ART, that antiretroviral therapy, TRUVADA will be used with multiple medications in combination to manage HIV infection. But this is kind of exciting. TRUVADA is actually used, it reduces the risk of getting HIV-1 infection when used together with safer sex practices. Now, it doesn't cure HIV-1 infection or AIDS. It does not do that. But it's actually used as something, it's called PrEP, P-R-E-P, pre-exposure prophylaxis, or PrEP. It's a way for people who do not have HIV, but who are at substantial risk of getting HIV. They use it to prevent HIV infection by taking TRUVADA every day. So when taken consistently, PrEP, this pre-exposure prophylaxis, has been shown to reduce the risk of HIV infection in people who are at high risk by up to 92%. PrEP is much less effective. It's not taken consistently. It's a powerful HIV prevention tool and should be also combined with condoms and other prevention methods to provide even greater protection than when used alone. People who use PrEP must commit to taking the drug every day and seeing their health care provider for follow-up every 3 months. So you know how hard it is if you've taken antibiotics for 7 to 10 days. You're like, oh, I cannot take it on the day of this. You start skipping it. TRUVADA is something you need to commit to, that you take every day. You need to almost think of it as like a thyroid medication that you have to take every day to replace thyroid hormone. If you're at high risk of getting HIV infection, to think that this could reduce your risk by up to 92% if you take it every day. The 92% is only for people that take it every single day. So I just thought this was very exciting. And I'm not even sure if your textbook talks about it, but I just wanted you to know about it. So it's called, the brand name is TRUVADA, and it's actually 2 separate drugs. It's tenofovir, and this is going to be a tough one, emtricitabine. So you combine those 2 generic drugs, those 2 antiviral medications, and the trade name is TRUVADA. I don't know how much TRUVADA costs, but if I was to guess, I would say it was pretty darn expensive. So here are some oral conditions that are related to HIV. You've probably seen some of these in your oral pathology: hairy leukoplakia, neoplasms, aphthous ulcers. There are also fungal infections that are related to HIV, NUG and NUP, viral infections, xerostomia, HIV drug interactions. So multiple drugs are usually taken in addition to other drugs that may be taken for opportunistic infections. So you're taking multiple antiviral medications. You may also be taking other drugs for opportunistic infections that have occurred, fungal infections, bacterial infections. HIV medications themselves, I want you to know this, may cause metallic taste, dysgeusia, which is like a yucky taste in your mouth. It's like an altered taste. Oral paresthesia, which is sort of like a numbness, and blood dyscrasia. So you may see that the person bleeds more. Here's a nice little picture showing you all the places where the nukes, non-nukes, integrase inhibitors, protease inhibitors, entry or fusion inhibitors work. So lastly, I think we're going to be talking about hepatitis. Chronic hepatitis. So chronic hepatitis is usually caused by one of the hepatitis viruses. Not A. A does not cause chronic hepatitis. It will be B, C, D. D does never occurs by itself. It only occurs with a co-infection with B, or E. So hepatitis C virus causes about 60 to 70% of the cases of chronic hepatitis, and at least 75% of acute hepatitis C cases become chronic. About 5 to 10% of hepatitis B cases, sometimes with hepatitis D co-infection, become chronic. No one knows exactly why a particular virus causes chronic hepatitis in some people but not in others, or why the degree of severity varies. Rarely hepatitis E causes chronic hepatitis in people with a weakened immune system. And again, hepatitis A does not cause chronic hepatitis. So what does hepatitis mean? Itis means inflammation, hepa means liver, inflammation of our liver. It usually presents with very few symptoms or none at all. Jaundice, you become a little yellow, anorexia, you don't want to eat, and malaise. Fatigue, like that's the complete blahs. So how is it treated? Chronic hepatitis is usually treated with a combination of antivirals and interferons. Antivirals are available for the treatment. These are some of the antivirals that are available for the treatment of chronic hepatitis B. Although the optimal duration of the therapy is unknown, many patients are treated for at least 5 years, and sometimes they are treated indefinitely. In some people, hepatitis B will reoccur once a drug treatment is stopped, and it actually can be more severe and life-threatening. So sometimes these people have to take antiviral drugs indefinitely if you have chronic hepatitis B. Treating hepatitis C can actually eliminate the virus from the body. Eliminating the virus from the body stops the inflammation and the scarring, which leads to cirrhosis of the liver. These drugs are usually well tolerated, although they can also cause headache, nausea, vomiting, diarrhea. Interferons are a large group of endogenous proteins. They have antiviral, cytotoxic, and immunomodulating action. They basically help to stimulate our immune system. So interferons are also used in the treatment of chronic hepatitis B and C. The FDA has approved interferons for treatments of B and C. Interferons have a bunch of adverse reaction. If it's serious enough, the interferon treatment may be stopped. And here are some other antivirals that are approved from the FDA for the treatment of chronic hepatitis C. None of these drugs for hepatitis will be on any exams. It's just for your knowledge that chronic hepatitis, basically know that it can be treated with some antivirals and interferons. So that is the last part of our anti-infectives. Camtasia.